So good evening, good afternoon, or good morning, depending from which part of the world you are joining us tonight to attend our third episode of Building Clinical and Research Confidence in Multiple Sclerosis. And actually today we host two speakers, expert in the field of multiple sclerosis, to discuss very interesting and hot topic in the management of the disease. Before introducing for you our first speaker, I would like to thank our sponsor, Novartis, for supporting our educational activity tonight. And I would like to remind you to leave your questions in the Q&A box. So I will take it after the first presentation for Dr. Nouri, as she has to leave right after her session. And similarly for Dr. Areen, we'll take the questions after his lecture. So please leave your question in the Q&A session. I would encourage you to benefit from the presence of two experts in the field of MS with us tonight to ask all your questions and concern about the management of the disease. With no further ado, I will introduce our first speaker for tonight, Dr. Suzanne Ibrahim Nouri. She's a senior consultant neurologist and multiple sclerosis specialist at University Hospital Sharjah, concurrently holding the position of an associate professor in the Medical College of the University of Sharjah. She is the proprietor and medical director of Dr. Suzanne Nouri Medical Center, located in Etihad Mall, Dubai. Her extensive expertise extend beyond the clinical practice, as she holds a joint academic roles within the Medical College and the University of Sharjah, and she actively contributes to research groups within the university. In her commitment to community awareness, especially in the field of MS, Dr. Nouri frequently organizes and speak at various meetings, forums, and media platforms, leading campaigns to raise awareness about MS. She's affiliated with numerous professional organizations locally, regionally, and internationally, and she actively participates in quality committees and task force. Dr. Nouri is one of the key founders and currently leads the scientific committee of the UAE MS support group, and she serves as an advisory committee member of the National MS Society and MS UAE. Additionally, Dr. Suzanne is a valid member of the Emirati Neurology Society EMINS and the Menactrem's Council Board. Dr. Nouri will speak to us tonight about the safety and efficacy of a new disease-modifying therapy, which are the high DMTs, in pregnancy and lactation, especially that MS is a disease that affects women in their age of adulthood, so in the age where they get pregnant, where they have the where the age of childbearing potential. So welcome, Dr. Suzanne. Please, the floor is yours and you can start your presentation.
Thank you very much, Dr. Maya, for the kind introduction, and thank you, IVPN team, for the opportunity to share with you insights. So just let me put my presentation. Can you please stop sharing so that I can share my screen as well, Dr. Maya, if you don't mind?
You can share, Dr. Suzanne.
Okay, so okay, sure. Now I can do. So you can see my screen now?
Yes, perfectly, Dr. Suzanne.
Okay. So I'm very pleased to be here this evening or morning or more afternoon, as I said, is to share some insights about the safety and efficacy of high efficacy multiple sclerosis therapies, especially in pregnancy and lactation. These talks provide practical overview of the use of these high efficacy therapies during this critical period of women's life, because it's important to keep health providers updated about the safety and the latest recommendations and the guidelines. So this is my disclosure. The outlines of the talk that I'm going to discuss challenges associated with the current ML therapies during pregnancy and lactation. We assess the available data and provide an updated comprehensive overview, especially of the monoclonal antibodies treatment in multiple sclerosis. They are used as high efficacy therapies. And we'll also talk about the existing clinical guidelines, expert recommendations regarding the use of these high efficacy medications. And of course, we're going to discuss the best practice recommendations. So we all know that hormonal changes during pregnancy have an immunomodulatory protective effect on women with multiple sclerosis, holding the disease under check. However, this protection might not be enough to control disease, particularly in those who suffer highly active disease. So these people usually they will require to be put on high efficacy therapy. And the current treatment paradigm that we know increasingly highlight the importance of early use of high efficacy treatment for a better control of the disease and prevent subsequent disabilities. Our data are very limited, and our evidence are very limited on the safety of these drugs during pregnancy, and that has led many women to interrupt or stop their treatment before completing their families. So they stop starting. They do not want to initiate their treatment until they have their families completed. So managing multiple sclerosis during pregnancy or during lactation presents unique challenges as many women with MS have not completed their families. As Dr. Maya just correctly mentioned that we all know disease affects women at the childbearing age between 20s and 40s, and this is the optimal time for them to think about having families. This lead to a complex decision about using medications during pregnancy and the postpartum. These women usually they face uncertainty regarding initiation of medication and they feel like they are going or they're walking into the unknown. They also feel the potential risk of these conventional medications on their developing fetus or on their breastfeeding infant. Moreover, deferring or delaying treatment due to family planning also puts many women at an increased risk of having permanent disabilities. In addition, treatment suspension or cessation for certain medications is associated with rebound disease activity, which can also potentially cause catastrophic relapses and permanent damage. And we also know that radiographic and the clinical disease activities usually fluctuate during pregnancy, which is associated with hormonal changes, and also during the postpartum, and that might also require a special consideration and might also require or necessitates a use of high efficacy medications. Of course, the absence of clinical activity during pregnancy does not equal necessarily complete control of disease because, as we said, that after delivery, sometimes we can find patients with multiple lesions without having any clinical symptoms or signs. And the biggest challenge is that we lack clear guidance and we do not have that enough data to inform which medications that should be used during pregnancy or in people with childbearing age. So the physician-patient conversation is quite essential for making a confirmed or informed individualized treatment decisions covering pre-pregnancy planning, pregnancy management, lactation, and in the postpartum period as well. Okay, let's move forward. In general, our approach for treating multiple sclerosis is either escalation strategies, as we used to do in the past. We start treatment with moderate efficacy medicines that had fewer or a high safety profile. And if that did not work well, then we escalate to more stronger ones or more efficacious ones. Now we have all the growing evidence that suggests and supports the early use of high efficacy medications for a better disease control and to keep disability on hold. So these high efficacy medications include induction therapies, which include alemtuzumab and cladribine, Also, we have the lymphocyte trafficking therapies, which include natalizumab and S1P receptors modulators, fingolimod, and the other. It's not commonly used nowadays. And we also have B cell depleting therapies, which include ocrelizumab, ofatumumab, rituximab, which is used in many countries off-label for treatment of multiple sclerosis, and the recently approved the obinutuzumab that is also used for progressive as well as relapsing multiple sclerosis. Just a quick overview on the high efficacy therapies. High efficacy disease modifying therapies are newer class of medications that have shown superior efficacy in managing multiple sclerosis by significantly reducing the relapses and delaying the progression of the disease. And these drugs play a crucial role in managing the severity of MS and are particularly relevant during pregnancy and lactation, as both the mother's health and the developing fetus need careful consideration. So I will focus now more on the monoclonal antibodies because these are very frequently used nowadays and that have also revolutionized the treatment of multiple sclerosis. Currently, we have 5 FDA approved and 4 EMA approved monoclonal antibodies for the treatment of relapsing as well as progressive multiple sclerosis, and these include natalizumab, Tysabri, which was first approved in 2004 and then suspended in 2005 and reintroduced in 2006. We have also alemtuzumab, Lemtrada, approved for relapsing remitting multiple sclerosis in 2013. We have ocrelizumab, approved 2017, ofatumumab, Kesimpta 2021, and we have the recently approved December 2022, the oblituximab, and we have also, as I mentioned, that rituximab, which is used off label in many countries. It is very crucial when selecting a high efficacy disease modifying therapy to balance the risk and benefits, particularly during pregnancy and lactation. So before prescribing any of these medications, doctors should always analyze the risks versus the benefit, and this has to be with an open discussion with the patients and her partner or his partner, because high efficacy therapies are very effective but may pose risks like birth defects and affect fetal development or breastfeeding baby. Therefore, clear communication of these risks is vital for both patients and the doctors to make, as I mentioned, a confirmed or informed decisions and taking into account, of course, the disease progression, the patient's status, reproductive plans, and the personal preference, because some patients might not be willing to go for some high disease medication, even though they are safer. So pre-conception counseling is a very vital step in doing so to discuss pregnancy possibilities with all women of childbearing age, and this should be done as early as possible, preferably at the time of the diagnosis. And the discussions need to be based on up-to-date evidence. And given the current rapidity of knowledge generation, this evidence should be revisited every now and then so as to be kept updated. And we also aimed for the period of disease stability, that usually we recommend for 1 year of disease stability before commencing pregnancy. And planned therapy switches or washout period should also be discussed to minimize the risk of fetal exposure to medication that can be teratogenic, and specialist referral if needed for a physiotherapy in patients with spasticity that can affect their delivery later on, or also advise if any pregnancy happens like unexpectedly or unplanned, to reassure the parents that most pregnancies result in healthy baby, and breastfeeding controlling disease activity before pregnancy will also mitigate the risk of having a relapse in the postpartum period. Relapses in the year after the delivery is very important to take care of, and this can be by controlling the year before the relapses, or breastfeeding exclusively can also mitigate the risk of relapses during the postpartum period, or reinitiation of disease-modifying therapy immediately after childbirth. And that also needs to be discussed whether the lady or the woman wants to breastfeed or she can receive high medications. Decision about how and when to stop treatment should also weigh the known risks and benefits. As a general rule, most disease-modifying therapy should be stopped before or when the pregnancy tests show positive results. So they can continue taking their medications until the minute they have a positive test, then they can stop the medicine to avoid potential harms to the fetus. However, for B-cell depleting drugs like ocrelizumab or ofatumumab, studies show that and suggest that drugs do not cross the placenta, especially in the first trimester, which might allow for safe continuation of the medicine until the end of the first trimester or safe continuation until pregnancy occurs. We also have evidence from their work that more than 2,000 MS pregnancies found no increased risk of adverse outcome with ocrelizumab exposure in utero. Another issue of stopping disease-modifying therapy is the risk of rebound or activation linked to certain medications like fingolimod and natalizumab when stopped suddenly. So natalizumab may be used for a longer interval period during pregnancy until the 34th week. So balancing the risk of the and the potential, because if we continue beyond the 34th week, that is associated with the risk of hematological abnormalities in the fetus. So until then, the patient can continue the natalizumab, and then they can stop safely afterwards. In some cases, we need to use transition medications or bridging therapies using the the B cell depleting cell drugs because they stay for a longer period active in the body, and they can be used to control disease symptoms before pregnancy, during pregnancy, or after childbirth for patients switching, especially from fingolimod and natalizumab. So when deciding on an MS therapy, we should take into account many factors like the need for the contraception, the washout period, as we mentioned, guidelines from the regulatory agencies such as the FDA, the EMA, the Health Canada, and the safety information from clinical trials and pregnancy registries also all should be taken into account. And for many medications, there are differences between the expert consensus statements and the product labels, and that's usually we have the product label usually very conservative, very restrictive, and that can lead to confusion. For instance, I'm just giving some examples here. Rituximab, the EMA and FDA and the Health Canada, they recommend avoiding pregnancy for 12 months after the last infusion. Ocrelizumab, EMA recommends 12 months, FDA recommends 6 months. Ofatumumab, they all recommend avoiding conception for 6 months. And for the obituximab, FDA recommends using contraceptive for 6 months, and EMA recommends 4 months, but it's not yet approved in Canada. So we have different recommendations from the clinical practice that we'll come to discuss in the coming slides. So the best practice recommendations here is shared decision making, and that should involve patients, their partners, if possible, and the clinicians. Family planning intent should be discussed, as we said, at each visit, not only at the early stage of the diagnosis. And planning pregnancy is also very essential, and follow up with the general guidelines, and especially for the supplementations with the prenatal vitamins, folic acid, vitamin D, and healthy lifestyle. They are all important for healthy pregnancy. Here is just an example of the pathway for clinicians treating women with multiple sclerosis of childbearing age. And for each decision step, the doctor must learn the goals of the patients, her concerns, and her lifestyle so that the most helpful information could be shared. And for the most important questions for patients getting pregnant or wishing to get pregnant, these questions are highlighted in blue, and that starts from the very beginning. If the patient wish to get pregnant, yes or no. If she has a wish, then is it an immediate or a future plan? And then we can just go through this one. It's just an example of how we can go through that. Okay. So now I'm going to focus more on the monoclonal antibodies, and this is our main topic for today, the high efficacy medications for the use during pregnancy. I will start with natalizumab. Natalizumab is one of the very old medications that has been approved for the use in high active disease. So it's a selective adhesion molecule inhibitor, binds to alpha-4 integrin, lymphocytes, and monocytes. It blocks interaction with the VCAM1, preventing leukocyte transmission across the blood-brain barrier. It's used for rapidly evolving severe multiple sclerosis or breakthrough disease. If the patient is on other medications, it's highly effective in suppressing focal inflammatory disease activities and also showed a high efficacy on slowing disease progression. For pregnancy consideration with natalizumab, there is no significant increase in congenital anomalies or miscarriages rates in over 500 natalizumab-exposed pregnancies. So it is safe in pregnancy, and the consensus recommendation is to continue treatment during pregnancy if required with extended dosage interval to reduce the maternal risk from treatment discontinuation. FDA and EMA advise discontinuing natalizumab upon pregnancy confirmation. So there's some discrepancy between the two. In the third trimester, we have also consideration natalizumab is linked to mild to moderate hematological abnormalities in infants like anemia, thrombocytopenia, leukocytosis, and this always resolve within 4 months after birth without requiring any special treatment. High risk of rebound relapses if the medicines discontinued before conception or during the first trimester, and these relapses usually requiring very high dose of steroids, plasma exchange, IVIG, and can lead to disastrous outcome and permanent disabilities. So the risk management for natalizumab use in pregnancy: lower relapse rates in women who stop natalizumab after the first trimester compared to those who stopped before the first trimester. So we can continue until the end of the first trimester and then to stop the medication because this can reduce the risk of relapses. Using the medication beyond the first trimester increases the risk of exposure for the newborn and leads to hematological abnormalities. So our current practice is to continue natalizumab until 30 or 34 weeks gestation with extended interval dosing and restart 1 to 2 weeks after birth. And the extended interval dosing is almost equally effective in preventing disease activity. We also have an alternative approach. So we can consider stopping natalizumab during the second trimester, again to minimize the fetal exposure, but also this can lead to a rebound effect on the pregnant woman. So we can also consider switching to immune depleting DMT, especially like ocrelizumab prior to consumption. This can be an alternative route. So we stop natalizumab before pregnancy, shifting to ocrelizumab, and then that can also give another alternative way of mitigating the risk. For infant care, we have to check for hematological abnormalities at birth, especially for the neonates who are exposed to natalizumab during pregnancy, and we should avoid all live vaccinations in infants exposed via transplacenta transfer during the third trimester. For the breastfeeding consideration, natalizumab is expressed in very little or very low quantities or concentrations in breast milk. There is no increased risk of hematological abnormalities in babies who breastfed with milk with natalizumab. A recommendation to continue natalizumab while breastfeeding due to its benefit, its safety for not affecting the babies with any abnormalities. So now we talk about alemtuzumab or Lemtrada. Lemtrada and alemtuzumab is an IgG1 humanized monoclonal antibodies, non-selective reconstitution therapy, and targets cell surface glycoprotein CD52 in some T cell and B cells lymphocytes. As a immune reconstitution therapy, it causes immune depletion and followed by repopulation later on. It's licensed for use in 2013 for patients with rapidly evolving MS or highly active disease. Pregnancy and breastfeeding consideration for Lemtrada, it's not recommended during pregnancy or breastfeeding, and both FDA and EMA advise avoiding pregnancy for at least 4 months after the last infusion. And serum concentration are very low, undetectable 30 days post-infusion. Okay. So for the risk monitoring, increased risk of immune-mediated conditions like immune thrombocytopenic purpura in 1% of patients and autoimmune thyroid disorders in 40% of patients. Especially during pregnancy, we need to do monthly blood and thyroid function tests. And there's also an increased risk for neonatal Graves' disease from the antithyroid antibodies. Pregnancy outcome, we have higher risk of a spontaneous abortion linked with the mother age. So if a woman age more than 35, there is a 37% risk of getting spontaneous abortion versus 15% for women younger than 35 years of age. And there is no increased risk of spontaneous abortion for consumption if happened less than 4 months after infusion, because the EMA recommendation is 4 months. So the recommendation is delay consumption for 4 months after the last infusion, and if any planned pregnancy occurs sooner, low transfer to fetus is reassuring, and then we have to reassure the pregnant lady with that. We should avoid all live vaccines in the mother or in the neonate, especially after the third trimester, to administer to neonates only after excluding hematological abnormalities. Breastfeeding can start earlier than 4 months post-infusion, although that we have the recommendation from EMA that we have to wait for 4 months. For ocrelizumab or Ocrevus, it's a humanized monoclonal antibody bind to CD20 expressing B lymphocytes. It depletes B cells through 4 mechanisms: antibody-dependent cellular phagocytosis, cellular cytotoxicity, complement-dependent cytotoxicity, and apoptosis. Ocrelizumab is indicated for active relapsing multiple sclerosis as well as active primary progressive multiple sclerosis. It is administered, as we all know, every 6 months through infusion. Pregnancy and breastfeeding consideration with ocrelizumab. It is not recommended during pregnancy or breastfeeding as per the label. FDA advises delaying conception for at least 6 months after the last infusion, and EMA advises 12 months. Low concentration serum 30 days post-infusion, minimal fetal exposure if consumption occurs later. Risk monitoring, we have largest registers in 2020 with the cumulative MS pregnancies included more than 700 pregnancies having in utero exposure, almost 40% of known outcomes, majority around 80% have live birth, and less than 1%, only 0.8%, they have major congenital abnormalities, 11% have spontaneous abortion. Another studies included 88 pregnancies, only 7% have spontaneous miscarriages, 15% preterm birth, and 2 congenital anomalies associated with exposure recent after the pregnancy. Because of the potential neonatal B cell depletion, live vaccines should be deferred until the B cells recover. So we have to check the levels before giving any live vaccination. Recommendations for ocrelizumab. MS specialists recommend trying to conceive without delay post-infusion or waiting, if more conservative, wait for 3 months post-infusion. Extended interval dosing based on CD19 count can maintain treatment efficacy, so it makes no difference whether to be taken every 6 months or little delayed. Clinical indication for use during pregnancy should consider risk of the neonatal B cell depletion, and we have to measure the CD19 B cell level in neonates before vaccinations. For the breastfeeding, it is considered safe despite not being approved. Low concentration in breast milk with low oral bioavailability reduces the infant absorption. For ofatumumab, mechanism of action is a fully human anti-CD20 monoclonal immunoglobulin antibody administered via subcutaneous injections every month, and it induces slices of CD20 B cells in both high and low CD20 expressing cells. It's not licensed for use during pregnancy, as we all know, and FDA and EMA recommend avoiding pregnancy for at least 6 months following the last injection. Pregnancy and breastfeeding recommendations with ofatumumab. We have not enough data on human pregnancy outcomes yet, and clinical trials and post-marketing surveillance included 32 pregnancies, showed 4 exposed within 6 months and 12 had first trimester exposure, 23 non-outcomes, 11 live births, 6 miscarriages, 6 elective termination. So the number is small, we cannot make any conclusion. No reports of B-cell depletion or immunoglobulin hematological abnormalities or any serious infection. Breastfeeding data show no effect on B-cell count in infants exposed during lactation. The recommendation for Kesimpta ofatumumab: stop injections when trying to conceive or when pregnancy happens, and patients with very active disease could switch to ocrelizumab before trying to conceive for longer lasting effects. Avoid live vaccines in mothers administered only after confirming the levels of the B cells. And for neonates, administered only after confirming also no B cell depletion. And because of its high molecular weight and low concentration in breast milk, ofatumumab is considered safe for breastfeeding, and this is our recommendations and our practice now. So for the new medicine, the obrituximab, I'm not sure how much experience people have here with that, but it's a chimeric glyco-engineered anti-CD20 monoclonal antibodies. It targets a unique epitope on CD20 B cells, and it's approved by FDA in December 2022 and not yet approved by EMA. Pregnancy and breastfeeding consideration with obrituximab, no data on the use in pregnancy or breastfeeding due to recent approval, of course, but expected to have similar characteristics to other CD20 monoclonal antibodies. The mean half-life is 22 days and likely minimal fetal exposure if last exposure or a last infusion is just before conception. It has unknown risk of major birth defects, miscarriages, or adverse maternal or fetal outcomes based on the studies. And the recommendation: FDA recommends administering the last infusion at least 6 months before trying to conceive. However, we need more human data so that we can measure also the concentration in breast milk and confirm safety. So the last one is the rituximab, which is used off-label, and we are using it more and more for treatment of NMO, but also some people and some countries are using it for treatment of multiple sclerosis. It's another chimeric anti-CD20 antigen on B cells, very similar to Ocrevus. It induces B cell lysis via complement-dependent cytotoxicity and antibody-dependent cellular cytotoxicity, and also induces apoptosis in B cells. For pregnancy consideration, FDA and EMA recommend stopping infusion of rituximab 12 months before consumption. Studies of over 200 pregnancies indicate no association with congenital abnormalities or adverse pregnancy outcomes, even within 6 months of the last infusion. And one study only reported 27% rate of spontaneous abortion, potentially linked to high pre-existing fertility rate. So the safety data for rituximab that comes from non-neurological conditions, we have more than 100 pregnancies exposed within 6 months before or during pregnancy. We have 73 live births, no teratogenicity, and the study of 21 women exposed within 6 months or during pregnancy, no miscarriages, no stillbirths, no serious infection, and 1 infant with multiple hemangiomas, whether related or not. The study on rituximab in pemphigus, that's dermatological conditions, 19 pregnancies, 17 have live birth, 1 termination, 1 spontaneous abortion, and 1 case of neonatal sepsis and with recovery. Recommendations: the current practice is to stop the treatment 3 months before or by the time of conception. Live vaccination should be avoided in mother and only administered after excluding B-cell depletion in the neonates, and breastfeeding is considered safe due to the very low concentration in the breast milk, because we know that it's really very, very minimal. This is just a summary of what I just listed to emphasize on 2 points: the placenta transfer, monoclonal antibodies typically do not cross the placenta, until the second trimester. That's reducing the likelihood of congenital malformations, but increasing fetal exposure as pregnancy progresses. For the infection risk, anti-CD20 therapies may pose infection risk to infants due to low B cell counts, requiring monitoring and specialist input for live vaccine safety. Injection therapy, we just mentioned that earlier, and also cladribine, because it's also high efficacy therapies. We should advise for use of dual contraceptive methods for 4 weeks post-dose and avoid conception for 6 months following a course. And men should also take the same precautions. And we're not going to discuss more on the cladribine. So before concluding, just to recap on the discrepancy between the clinical recommendations and the regulatory recommendations. For natalizumab, as we mentioned that high risk of rebound disease activity can be continued till 34 weeks of gestation, and check infant for hematological abnormalities, and it's safe for breast feeding because of very low concentration in breast milk. Now, EMA and FDA advise discontinuation upon pregnancy confirmation. Alemtuzumab, on the other hand, the last dose should be 4 months before consumption, no risk for exposure during pregnancy, monitoring for autoimmune diseases, especially during pregnancy and grave disease in neonates, and breastfeeding can start 4 months after the last infusion. And EMA and FDA recommends avoid pregnancy for at least 4 months after the last infusion. Ocrelizumab, the last infusion when pregnancy is confirmed or 3 months before starting to try conceive, and check infant B cells for depletion and safe for breastfeeding because of the very low concentration. And EMA recommends 12 months and FDA recommends 6 months. Ofatumumab, the last injection should be when trying to conceive, and check again for the B cell depletion in infants, and is safe for breastfeeding. Sorry, why it's not coming? And all recommendation avoid conception for 6 months. For the oplitoximab, insufficient data, but similar to ocrelizumab, and again we have to check for the B cells depletion for the infants. And FDA recommendation is 6 months after the last dose. EMA recommends 4 months and not yet approved in Canada, so there is no recommendation. For the rituximab, just let me go back. For the rituximab, as you mentioned that FDA recommendations is avoiding consumption for 12 months post the last infusion. So my last slide is just to summarize a few points. Family planning and pregnancy management requires the most current and updated information, and the treating doctor should discuss family planning at the time of diagnosis and on each subsequent visit, and again should refer to the recent guidelines. And we have to emphasize the importance of shared decision making in family planning, involving the risk and benefit and analysis of the patient's need. And we need more real data for DMT exposure during pregnancy, and because that can take many years to collate due to safety concerns. And pregnant registers and trials focus on pregnant and lactating patients should provide additional data to guide us for management of multiple sclerosis. And if we are looking for the change of the regulatory change or achieving a regulatory change, that can take decades, because before the changes of any of these regulatory, we know this from what happened to interferon beta, which recently got approved to be like safe during pregnancy and lactation. And with that, I would like to thank you for your attention, and these are my references.
Thank you, Dr. Suzanne, for a very, very comprehensive presentation. I know for this topic, we can just discuss for hours regarding the use of disease-modifying therapies in pregnancy and all the data, especially as you mentioned, the discrepancies between the original label of the medication and the emerging data from pregnancy registries about the safety of the medication. So if we look at the the label of the majority of those medication, there are discrepancies between the label and the updated recommendation that we are receiving from the pregnancy registry, which are collecting data about the safety of their use in pregnant women. I would like to recommend and to encourage our attendees to write their questions for Dr. Suzanne now in the Q&A box, as she has to leave after her presentation. And I will start, Dr. Suzanne, with the first presentation. So how do we decide, or what are the criteria that we need to look into to decide whether to continue or to discontinue a disease-modifying therapy for an MS patient during pregnancy, of course?
So thank you for the question. And the criteria, of course, dependent on so many factors. First of all, we have to see the disease specifications, so like the disease severity of the patients, the severity of the high load lesion, the number of the brain lesions, the clinical condition of the patient, and if the patient is physically fit for getting pregnant or not, the disease, the modifying therapy that the patient is taking at the time of getting pregnant or planning to get pregnant, because all of these can be taken into account before deciding which medication they should continue or which medication we should start. I don't know whether this answered the question.
Yeah. And another question that is related to what you just discussed. So what are the ethical considerations that arise when decided whether to continue or discontinue is modifying therapy in MS patient? And would patient autonomy here play a role or to stop by
Regarding
themselves?
regarding the ethical consideration here, because of course it is not ethical at all to start any medication for a pregnant woman. And that's why we say the importance of an informed decision making here. So if there is an agreement between the clinician and the patient that they would like to continue, of course, this would be with advice of the clinician, depending on the disease severity and the condition of the pregnant woman. So if they approved or if they agreed to continue medications, usually we choose the safest. And that's why we said from the very beginning at the early stage, when the patient is diagnosed with multiple sclerosis, we have to ask about the planning, any plans for pregnancy, because that is the time that we choose which medication we should start on. So for a pregnant woman or for a woman who wish to get pregnant, we always go for the safest medicine that she can continue until she gets the pregnancy positive test, or even if she needs to take that medication throughout her pregnancy, then we can do so with medication that we think has a safety profile that can allow her to get pregnant throughout the pregnancy period. Like natalizumab, for example, this can be used until 34 weeks without any problems. So, and we know from the registries that there was no any congenital malformation, there was no teratogenicity for the babies born for natalizumab exposed infants.
Thank you, Dr. Suzanne. Another question. So almost all the DMT, they are advised to be discontinued before conception or during conception. So how our MS patient will be managed and protected until they get pregnant? You know, some women might try to get pregnant, but they might not become pregnant until like 3, 4, 5, 6 months of trying to conceive. So how do we treat those patients, or how do we protect our MS patient from having breakthrough relapses during the conception period?
Yes, all recommendations, this is stop with DMT. So this is according to the regulatory recommendations. All DMT should be stopped before getting pregnant. But as you mentioned that, we have to consider the patient's condition, the disease status. So and we know that some patients might not get pregnant easily, as you mentioned. There can be a delay in getting pregnancy, and that is a very risky period where the woman can get a disease relapse or they can get a rebound effect. In that case, the choice of the medication is quite important. CD20 medications, especially like ocrelizumab, because they have a longer effect, so they can cover for 6 months because this is how the medication is given every 6 months. So in that case, acrelizumab will be a best option for these ladies, for this woman. Of course, we have to consider also to avoid all the triggers that can put them into relapses, like avoiding heat, infection, and other things. Of course, taking their medications, vitamin D, especially because it can also like a protective effect. So the choice of medication here will be very important to give a good protection during the time that they are trying to conceive. Okay, or else they can be started. It depends again on the status. They can be put on some medication like interferon beta, for example, and this can be taken throughout pregnancy, throughout the breastfeeding as well. So again, we just come to the same point that depending on the disease activity, depends on the patient condition, the choice of medication should be considered.
I totally agree, and if you allow me, I would add also one more thing that so usually in clinical practice we don't allow patient to have active disease to get pregnant. So usually we advise our patient to try to conceive whenever they have a stable disease for at least 12 months, and this will avoid them to have any relapses or decrease the chance to have any relapse during the conception period whenever they stop the medication, or even during pregnancy whenever they stop the medication. So usually only stable women, they are advised to try to conceive to avoid any breakthrough disease. And as Dr. Suzanne mentioned, the other strategy would to shift to other drugs that are safe to be continued until the pregnancy test is positive, so until pregnancy occurs or during pregnancy, like interferons or natalizumab. And the final question for you, Dr. Suzanne, before we move to Dr. Said's presentation. So, do we know how and or if high efficacy disease modifying therapy affect the fetal immune system, immunity? So, do we know if those high efficacy immunosuppressive medication they will affect the immunity of the fetus?
Of course, yes, we can
Do
know
we have
this.
data?
Um, yeah, we know that natalizumab, for example, can cause some hematological abnormalities, especially if given after the first trimester. Okay, but for other medications like CD20 depleting cells, B cell depleting cells, they can lead, or even like elotuzumab or other medication that can reduce immunity, like immune reconstitution therapy. The baby can have a reduced B cells, and that's why it's quite important to check the immune cells and the B cells for these infants, just to make sure that they are not affected by the immune suppressant medications. As for the alemtuzumab, for example, a baby can also be affected by Graves' disease because the antithyroid antibodies in the mother that can cross the placenta. So that again, they can affect by the immune therapy of the mother.
Yeah. Thank you, Dr. Suzanne, so much for accepting our invitation, for an excellent presentation, and for answering all the questions. It's always a pleasure to have you among us. Thank you again. And
The pleasure is mine. Thank you very much.
you, Dr. Suzanne. And I will move to introduce for you our second speaker for today, and also an expert in the field of MS with long years of expertise in the management of MS patient. But before that, allow me to remind you to write all the questions for Dr. Said in the Q&A sessions. And also, I would like to remind you, because I'm receiving a lot of questions regarding the CME accreditation. Yes, this webinar is a CME accredited, and you will receive your certificate of attendance within 1 week of today. So, Dr. Said, it's an honor to have you with us today, and thank you for accepting our invitation. Dr. Said is a consultant neurologist and director of neuroscience department at the American Hospital in Dubai, UAE. Excuse me. Yes, he's a clinical assistant professor of neurology at the University of Sharjah and Gulf Medical University. He's a diplomat of the American Board of Psychiatry and Neurology, an active member of the American Academy of Neurology. He is also a past clinical assistant professor of the neurology at the University of Illinois College of Medicine at Peoria. He is also a past co-director of the MS Center at OCF INI and past division chief of neurology at the Wilmington Health Associate in the USA. Dr. Saeed is the recipient of the Sylvia Laurie Multiple Sclerosis Fellowship Award from the National MS Society and has published many peer-reviewed medical journals. Dr. Saeed will discuss today the real-world experience and the real-world data of ofatumumab. So as you know, ofatumumab has well-established clinical efficacy and safety in pivotal clinical trial, but Dr. Saeed will inform us today about its real-world safety and effectiveness. Dr. Saeed, it's our honor again to have you with us tonight. Thank you for accepting our invitation, and you can start your presentation.
Thank you, Dr. Maya. Thank you also, Dr. Suzanne, for your earlier presentation. I know you have left for existing commitments. Allow me also to thank IVPN and also Novartis, our sponsors for this program. Allow me also to thank all the audience for coming at this evening, probably, or morning in some of the other countries. The talk today will be regarding ofatumumab, a monoclonal antibody targeting the CD20 B cell from the clinical trials to the long-term 6 years data and real-world experience. Now, we know that MS has a burden on our patients. We realize that more than 30 to 50% of the patients with MS can have depression and anxiety. And not only patients have physical disabilities, but 50 to 70% of the patient can have cognitive difficulties, which impair the social interactions and social activities. Actually, cognitive difficulties can be observed even years before patients can develop their first physical motor disability. Fatigue is one of the common causes of disability in MS patients, and it can affect almost 80 to 90% of MS population. Pain and discomfort and limited mobility secondary to motor or cerebellar dysfunction can all lead to a burden in our MS patients. All of this will lead to reduced employment, and we know that as the disease progresses in years, there is high chances of a progressive nature of their disease. And the goal of using all these immunomodulating agents is particularly to try to minimize the disability that can occur over time in MS patients, and also to limit the disease progression. Okay. Now, we know that with increase in the expanded disability score, the chances of employment become less, and it's very important to stop the disease from progressing very early. Now, when we decide to use drugs for MS patients to minimize the relapses and eventually to minimize the progression of the disease, there is always this balance between the safety of the product that we are using on the patients, but also the efficacy. So we could choose a drug that is more safe, but may have a modest efficacy. And this was our approach a decade or two decades ago, until recently when we started to have higher efficacy drugs where there is, the slide is not moving, I apologize for that. Right. Here we go. As we mentioned, historically, we used to start with a modest drug in relation to efficacy. And then if the patient have a relapse or a progress, then we switch to a higher efficacy drug because we were concerned about the potential role of the adverse events of these drugs. The other school actually will use high efficacy drugs, as Dr. Suzanne alluded to, because we know using high efficacy drugs early in the disease will impact the long-term progressive nature of the disease. And so studies have shown that if you are not on a drug or you are using a modest or low efficacy drug compared to high efficacy drug over the course of 10 or 15 years, if you are using a high efficacy drug from the onset, the chances of your progression is significantly less than if you started with low efficacy drugs. And so patients with MS really need to start high efficacious treatment early in the disease course. And that's why now we are using these monoclonal antibodies to treat our MS patients. And we have limited the use of the old immunomodulating agents, although some patients may still benefit from them under different circumstances. Now, we are talking about a group of drugs, particularly the anti-CD20, which are drugs that target the cluster of differentiation or CD20 on the surface of, mostly in the surface of B cells, although it's available on other cells, but we are mainly talking about the B cell carrying the CD20 marker. Now, this comes from different sources that B cells play a role in the pathogenesis of multiple sclerosis. In the past, we used to believe that MS is mainly a T cell-driven disease, but data from different trials and particularly the use of off-label use of rituximab 10 or 15 years ago to treat MS patients led and the clinical benefit for patients who were receiving it led to the belief that B cells do play a role in the pathogenesis of MS. And certainly, when additional histological data from MS lesions found that actually B cells are present not only in active lesions, but also in chronic expanding lesions and chronic plaques. We know also that the memory B cells could be also found in the ectopic germinal centers in the meninges, which can be a source for the progressive MS disease. We know also that there is immunoglobulins that are specific for myelin oligotentroside glycoprotein and the myelin basic protein in the brains of patients with multiple sclerosis. Additionally, we know about one of the common diagnostic biomarker in MS patients is the availability or the presence of oligoclonal bands and increase in the IgG synthesis and index in the CSF. And that the presence of these bands can actually increase the chances of having a progressive MS compared to those patients who have no oligoclonal bands. And lastly, when studies were done on experimental allergic encephalomyelitis models of rodents, the presence of B cells was required to promote the T cell responses as playing as an antigen presenting cells. So all this data suggests that indeed B cells have a major role in the immunopathogenesis of multiple sclerosis. Dr. Suzanne also alluded to different monoclonal antibodies. We know chimeric antibodies are antibodies that are mainly made from like rodents or rats, like rituximab or oblituximab. Then there is a humanized monoclonal antibodies such as ocrelizumab, which was approved around 2017, and then the ofatumumab, which is a fully humanized or a fully human monoclonal antibody. And these monoclonal antibodies target different parts of the CD20 and also can induce B cell apoptosis by either the ADCC or the cytotoxic dependent cytotoxicity, and they can induce apoptosis of the B cells. Ofatumumab is a fully human monoclonal antibody that has no mouse sequences, and this suggests that it may have less immunogenicity compared to the chimeric or the humanized monoclonal antibodies. Now, where does the data regarding the efficacy and safety of ofatumumab comes from? Well, there were, as all of you know, the Asclepius 1 and 2 trials. These are the trials that enrolled patients on ofatumumab sub-Q injection versus patients who were receiving teriflunomide. And this was a double dummy study, meaning patients who were receiving oral teriflunomide received also a placebo subcutaneous injection, and those who were receiving the drug ofatumumab received a placebo oral tablet. And these were followed up for a course of 2 years, and this was the core study, and then they were followed up for safety after the completion of the study. The ofatumumab was given on day 1, day 7, day 14, and then monthly after that. So the loading dose is over 3 weeks, and then monthly or every 4 weeks after week number 4. Each study had more than 900 patients, and the patients were adult patients with relapsing forms of multiple sclerosis with an EDSS of 5.5 or less. This shows the key inclusion criteria. So these are relapsing remitting MS patients or secondary progressive MS patients with the presence of a component of activity. These patients should have an active disease before enrolled in the trial. So either they have more than 2 relapses in the last 2 years or more than 1 relapse in the last 12 months, or a positive gadolinium enhancing lesion suggests that there is an active disease prior to enrollment in the trial. And on the right side of the slide, you can see the main exclusion criteria. Any patient who had no active form of MS was excluded. Patients who met criteria for other acquired or other acquired demyelinating disorders were also excluded. Patients who have a possibility of a benign MS, i.e. those patients who have a long disease course, but their disability score is very minimal, among other exclusion criteria. This is to show the baseline characteristics between these groups, and they were relatively comparable without major significant differences in the age or sex or the duration of their MS, the clinical status of the disease, and the MRI lesions. So here, this slide shows the effect on the annualized relapse rate comparing ofatumumab to teriflunomide in both the Asclepius 1 and Asclepius 2. There was more than 50 to 58% reduction in the annualized relapse rate between the two groups. The way you read this slide is that at the end of the 2 years, patients who were on teriflunomide in a gray color had about 0.22 annualized relapse rate. That means about 1 relapse every 5 years, compared to 1 relapse every 9 years on the ofatumumab arm. Similarly, on the Asclepius 2, it was about 1 relapse every 4 years in patients who are on teriflunomide, compared to a relapse every 10 years in patients who were receiving ofatumumab. Also, ofatumumab showed a significant delay in the 6 months and the 3 months confirmed disability worsening. So if you look at the left side of the graph, you can observe that patients who were on ofatumumab had almost 10.9% compared to 15% chances of cumulative progression into 6 months confirmed disability worsening. And this is looking at the 3 months and 6 months confirmed disability worsening. Now, if you look at confirmed disability improvement, so this is those patients who had achieved a chance of improving their disability improvement, and it was sustained for 6 months. You can observe that patients on ofatumumab, 11% has that chance compared to 8% on ofatumumab, suggesting that there is a trend of 35% increased chance of achieving an improvement in confirmed disability improvement in patients who are on ofatumumab versus teriflunomide, although it was not clinically significant. This is an effect on the gadolinium enhancing lesions, and you can see dramatic response of patients who were receiving ofatumumab compared to teriflunomide. Almost no active lesions in patients who did receive ofatumumab, roughly about 1 gadolinium enhancing lesions for 100 MRI compared to on patients who were receiving ofatumumab compared to about 1 lesion for each 2 or 3 MRIs in patients who were receiving teriflunomide. Similar effect also were noted on the new or enlarging T2 lesions, although the effect was not as robust as the gadolinium enhancing lesions. But at least there was about 80 to 85% reduction compared to the teriflunomide arm. Looking at the adverse event profile between the two groups, there was relatively comparable side effect profile where serious adverse events were in about 8% in patients who are receiving teriflunomide to about 9.1 in patients receiving ofatumumab. The most common adverse event if it was reported more than 5% is what is present on this table. Diarrhea was more common seen in patients who were on teriflunomide, and injection site reactions were more commonly seen in patients who were on ofatumumab, and slightly more urinary tract infection by about 2%. Now, this is a table that shows also relative comparability of the serious adverse event. There was no major difference between infection and infestations. Malignancy was relatively the same between 3 cases on teriflunomide and 5 cases on ofatumumab, in addition to other nervous system disorders not clarified. And there was 1 death in both studies that was related to aortic hemorrhage. It was reported in the teriflunomide arm. Now, in reference to the injection site reactions, most of the injection site reactions were mild to moderate. There was only 1 patient who had a grade 3 reaction, but it actually resolved after a month, after actually the first injection, and there was no more reported systemic injection reactions of a grade 3 after injection number 1. So in summary, the trial for phase 3 trials of Sclerosis 1 and 2 revealed the superior efficacy in lowering relapses rates and MRI activity. There was significant reduction in both the 3 and 6 months confirmed disability worsening, and there was a trend regarding confirmed disability improvement. Patients had lower levels of serum neurofilament light chain within 3 months and all subsequent visits. And there was a favorable safety profile with no unexpected safety signals utilizing ofatumumab 20 milligrams sub-Q every 4 weeks after the loading dose. Perfect. Now, we are just going to spend a few minutes to cover the long-term safety and efficacy of ofatumumab. So, the drug came to the market after these 2-year phase 3 trials showed meaningful clinical efficacy as well as a meaningful MRI results, as I mentioned earlier. And many patients who were in the phase 3 trials, which are the Sclerosis 1 and 2, were followed in addition to the patients who were in phase 2 trials, were also included in the long-term 6-year data. So the treatment of ofatumumab up to 5 years showed sustained efficacy and favorable safety profile. during this open extension Alethio's trial. And also, it is important to assess the safety and long-term efficacy in MS patients. And this is what we will discuss now in the next few slides. So here, if you look at the left part of the screen, if you look at the half part of the screen is those patients who were on Asclepius trial. Red were the patients who were on teriflunomide through the course of the trial, and then they switched to ofatumumab. And then there is the core trial, which were ofatumumab, and they continued. Some of them elected to be part of the Alethio's trial, about 700 patients from the original ofatumumab patients, and then almost 680 patients who were originally on teriflunomide but switched to ofatumumab. And then from a couple of other trials, the Apolitos trial, which was trial, if believed done, it was a phase 2 trial in Japan and another country, and also the Apelius trial. These are phase 2 trials. They were also enrolled, part of them enrolled in this Alethio's extension trial. So this is the total number of patients, and the goal was to look at really, did we have a sustained efficacy on the annualized relapse rate and MRI measures, and what happens to the 6-month confirmed disability worsening and the term no evidence of disease activity, which looks at the clinical status of the patient with where there is no relapses. It evaluates also the absence of any progression and the absence of any new enhancing or T2 MRI lesions, and also to look at the safety of this drug when used through these 6 years. So this slide shows that looking at the no evidence of disease activity 3, which are looking at this clinical and MRI outcomes in the patients who were receiving ofatumumab in the Asclepius 1 and 2. In the first year and 2, there was rapid initial increase in NIDA3 with continuous ofatumumab, and this high rate of NIDA3 was maintained over 6 years. So if you look at the dark blue color are the patients who were on ofatumumab through the course of these 6 years. So this is the bar on the left. You can observe that more than 80 to 85%, actually more than 85% in year 3, 4, 5, and 6 were without any disease activity. Now, those patients who were originally on teriflunomide did not have high NIDA in the first 2 years, but when they switched to ofatumumab, there was significant increase in NIDA3, suggesting the higher efficacy of ofatumumab compared to teriflunomide, and that patients who were switched from ofatumumab to who were switched from teriflunomide to ofatumumab have increased in their NIDA percentages. This is also to confirm the earlier data. We talked about patients who were in the core phase with ofatumumab had their adjusted annualized relapse rate dropped to almost 0.1, again, the number of 1 relapse every 10 years, and almost 1 relapse every 4 years for teriflunomide. But if you look after 2 years and you follow them for 6 years, there was actually a 49% reduction in the actual annualized relapse rate of those patients who were on ofatumumab and continued on ofatumumab, and more than 73% reduction in the annualized relapse rate in those patients who were on teriflunomide and then switched to ofatumumab. And then if you look at the differences between the group comparison between those who were continuously on ofatumumab and those who were originally on teriflunomide but switched to ofatumumab, you can still see that there is a major significant reduction in the annualized relapse rate after conversion from teriflunomide to ofatumumab. Again, these numbers also were sustained for 6 years in relation to the gadolinium enhancing lesions. So the continuous ofatumumab group was associated with significant reduction in the mean number of lesions per scan by almost 57% with the longer term use, and switching patients from Abajo or teriflunomide to ofatumumab also resulted in an almost complete suppression of these gadolinium-enhancing lesions. As well as if you compare the group between each other, you can see that there is significant reduction in the mean gadolinium-enhancing lesions once you start ofatumumab compared to teriflunomide. This data is also impressive. If you look at the 6 months confirmed disability worsening, it was sustained even up to 6 years. So if you look at the slide on the image on the left, the red is patients who were on teriflunomide, and then the light blue is actually patients who were originally on teriflunomide but switched to ofatumumab. The dark blue is patients who were all from the onset on ofatumumab. And you can see there is about 124 patients on the teriflunomide arm who did reach 6 months confirmed disability worsening in the core trial, compared only to 105 patients on the ofatumumab arm. And this is about 15% reduction between the two groups. But also, if you followed the total number after 6 years, you see only 164 patients on ofatumumab did reach this 6 months confirmed disability progressing, compared to 191 originally on ofatumumab but switched to teriflunomide, originally on teriflunomide but switched to ofatumumab. And again, this reduction of 14 to 15% was sustained through the 6 years. So this suggests that actually using the continuous ofatumumab treatment was associated with significantly lower number of 3 months and 6 months confirmed disability worsening. And that's why it's recommended to start high efficacy drugs, because once you reach this cumulative disability worsening, it's going to continue to be with you, and you are not going to catch up if you develop that 6 months or 3 months CW events. Looking at the safety profile in patients again over the course of the 6 years, and looking at the exposure adjusted incidence rate, again, the number of infections or serious infections was relatively comparable between the two groups, and no major changes in the number of deaths or malignancies or significant changes over the 6-year course. This is to describe the incidence of the serious infections. It was reported that 6 fatal cases reported were due actually to 5 of them were related to COVID, and 1 was due to pneumonia. There was 1 serious opportunistic infection, but there is some discussion as per the slide that it was not confirmed to be related to the pneumocystis jirovecii, and it was reported that the patient eventually clinical condition resolved even with continuation and no interruption of ofatumumab therapy. Now, there is a lot of discussion regarding the mean IgG and IgM levels in patients who are receiving ofatumumab. Generally, most patients had their IgG level above the lower limits of normal, and as well as those with IgM, although it dropped, but not significantly below the lower limits of normal, as you can see on the slide. Also, the drop of this levels was not associated with increasing the risk of infection or serious infections. So in conclusion, for the long-term data, at year 6, almost 90% of the participants were free of disease activity in both the continuous and those who switched the therapy. Continuous ofatumumab treatment was associated with fewer confirmed disability worsening, up to 6 years versus switching from teriflunomide, supporting the long-term benefit of earlier initiation of high-efficacy drug, particularly ofatumumab, which cannot be recovered in those initially randomized to teriflunomide. The sustained efficacy of ofatumumab for up to 6 years was accompanied by a consistent safety profile with no unexpected safety signals. The mean IgG levels remained stable, whereas the mean IgM decreased but remained above the lower limits of normal, and there was no clinically meaningful association between the reduction of immunoglobulin levels, both IgM and IgG, and risk of serious infections. All of this support the long-term favorable benefit risk profile of ofatumumab treatment, at least for up to 6 years, and reinforce the benefit of high-efficacy drug initiation in patients with relapsing forms of multiple sclerosis. With this, allow me to thank you, and I will have Dr. Maya take the microphone from here. Thank you.
Thank you, Dr. Saeed, for a very enriching presentation summarizing the efficacy and safety of ofatumumab, whether in clinical trials or in real-world setting, and focusing on the long-term data. So I will start by from where you ended your presentation. So does this real-world experience or long-term safety data of ofatumumab changed any of your current practice for the use of ofatumumab? So do you have any modification in the dosing, for example, for the monitoring strategies, or no?
So a couple of things I probably should answer this. So the data regarding the anti-CD20 in general, ofatumumab and other anti-CD20 such as ocrelizumab, did shift our practice in the last 5 to 7 years. So indeed, the data with the anti-CD20 and in general the good safety profile have made me personally use these drugs very early in the disease because the data shows that high efficacy treatment can modify the long-term disease outcome. And yes, for that reason, I am treating my patients with these drugs. Now, this data about the safety and or modifying the dose of anti-CD20, yes, in the last 2 years, and particularly after the COVID pandemic era, and since many experts were stopping these drugs, particularly the intravenous forms, it has been shown, at least in some trial, in some observatory data or clinical cases, that there is an extended interval dosing recommendation in patients who are receiving the intravenous form of ocrelizumab, where they are following their CD19 or CD20 B cells. And if in 6 months they are at 0 or they have not repopulated, then the level would be repeated after 4 weeks. And if still the B cells have not been repopulated, the dose is pushed again for another month until there is about 1% of these B cells repopulated, or between 10 to 25 cells per microliter have been populated, and patients are receiving further dosing.
Thank you, Dr. Saeed. Another question. So also, as you mentioned now when answering the first question, so we moved, like, the strategies for managing the MS disease has changed significantly over the past year with the emergence and the approval of those high efficacy DMT. So traditionally we used to follow the escalating approach, where we started our patient on platform therapy, which are the low efficacy drug. We monitor, and then we escalate patient on high efficacy DMT whenever there are breakthrough disease. However, nowadays all the guidelines, all the study, they are changing toward starting our patient with high efficacy DMT even early on after the diagnosis. So what are the barriers for starting patients on high efficacy DMT and on ofatumumab specifically as first line therapy?
The barriers, I mean, if you are referring to barriers as challenges, there
in real world?
in real world, the challenges
Yes.
is the drug available in all countries or not?
Yes.
You know, that's a challenge, you know, because many countries may not have these drugs available for them, so it will limit the chances for patients to receive it. The other barriers that we may encounter is insurance.
Insurance coverage, yeah.
Yes, cost coverage would be another barrier. But if we look at the other side, you know, we can say that it is one of the drugs that is easy to use if we can bypass these barriers. It can be easily monitored. Um, Very minimal serious serious side effects that I can recall. I have seen any actually in the last, you know, 3 or 4 years. Other barriers would be, you know, the question of pregnancy or lactation. But we know that ofatumumab is not contraindicated with breastfeeding, so it will be actually a drug to use in these circumstances.
Yeah. Uh, since we mentioned cost and insurance coverage as a barrier to treatment, one of the attendees is asking if we have any effectiveness study for effectiveness study considering the direct medical cost and indirect medical cost of the treatment.
Sorry, Dr. Maya, there was some interruption in the
Yeah.
last part. Can you, yeah.
Yeah, so do we have any cost effectiveness study of evaluating the cost effectiveness of ofatumumab and taking into account the direct medical cost and in the indirect medical cost of the treatment?
There may have been, I do not, I cannot with certainty say yes. I probably did hear that there was some comparative trials, but it's not on my mind right now, so I cannot really say yes or
But
no.
probably if we think about it the basic way, if we want to think together, with ofatumumab, we are saving the cost of hospitalization compared to other B-cell depleting therapy because it's a subcutaneous injection. The patient doesn't have to be admitted to the hospital to take it, probably. But I'm not aware as well of any cost-effective study
I,
comparing.
I, I think there is something, but not published yet.
Yeah.
But you are right. I mean, it's a medicine that is taken generally at home. There is no need for a fusion. And I
Yeah.
think this cost effectively trial was done actually in UAE, but I believe it's not published yet. So until it is published, you know, we will have more data.
Yeah, moving to more practical question about the use of ofatumumab itself. So what are the baseline tests that you usually perform before initiating ofatumumab? So do we need to do any IgG, baseline IgG level to monitor for hypogammaglobulinemia? Is this routinely done? And what are the other baseline tests that you do as well as the follow-up lab tests that you need to monitor the patients?
Okay, so I'm going to tell you about my practice,
Yeah.
and maybe different a little bit about other colleagues or what is in the package insert. So any patient whom I'm going to start ofatumumab, we do complete blood count,
Yeah.
we do liver function test, we do creatinine, and these are mandatory. Then we check for the following 5 things: varicella zoster, IgG, and IgM. We send for TB quantiferon test, HIV, hepatitis B and C screening. And that include the hepatitis B surface antibody, hepatitis B core antibodies, and the hepatitis C antibody. And in my practice, I do baseline IgG, IgM, and IgA. Although many of my colleagues do not do that, but I do that. And every 6 months, I repeat CBC, liver enzymes, creatinine, immunoglobulin levels, and in the last 2 years, I add also CD19, CD20 B cell percentages, particularly in patients who are receiving intravenous ocrelizumab. because I am modifying the dosing interval for those patients who are stable and their B cells have not been repopulated. And again, this is off-label, but we are giving the drug sometimes every 8 or 9 months for those patients.
And since you are monitoring CD19 and CD20, so here also we have the same practice, but honestly, we don't repeat the IgG level routinely. We do a baseline one, but we don't repeat it unless the patient report frequent infections. So we ask for the repeat. And for the CD19, CD20, for those who wants to extend the dosing interval, and yes, we follow the same practice. So we repeat CD19 and CD20 test in order to decide on the dosing interval. But my questions here for you, so any correlation between the CD19, CD20 level and the breakthrough disease? So did you notice any correlation? For example, when the CD19, CD20 subside, there is relapse, or sometimes relapse are not correlated with a low CD19, CD20 count?
Okay, very good question. I have more than 2 or 3 dozens of patients on anti-CD20, actually probably like more than 40 if I add, combine all of them. I had no patient who had any relapse or any active lesion except one patient. And that one, I cannot recall if there was any association between, it's not on my mind, but rarely we see patients with relapses or active lesions while they are on these anti-CD20 drugs, and they are really efficacious.
Yeah, I totally agree. And another practical question, so if we want to move a patient from ocrelizumab or rituximab, so the IV B-cell depleting therapy, to ofatumumab, so any special consideration, any washout period, anything special that should be done when we transition a patient from the IV depleting therapy to the sub-Q one?
I would not believe there is anything. It's not about wash period, right? So somebody who's on ocrelizumab and took it 6 months ago, and now they want to go to ofatumumab. So certainly, I will not give ofatumumab after a month or 2 or 3 or 4 or 5 from the ocrelizumab. But then when month 6 comes, I probably will repeat the CD again 19, and if there is no repopulation, I will wait, and then if they are repopulating, I will start the ofatumumab. Now the question becomes, do I need to load them or not?
Yeah,
Probably I will.
you will load them.
Probably.
And the final question for you, Dr. Saeed, not to delay you and delay Dr. Dimasi. So do we have safety data about the use of ofatumumab in special population, mainly in elderly patients, and especially those patients who have other comorbidities?
All right. So, the clinical trials enrolled patients up until the age of 55. I don't have all the numbers of these patients. If most of the patients were enrolled when they were 50 or less, so the long-term extension data will have very few patients above the age of 55. So I really don't have that data. Do we use it for our patients who are above the age of 55? Yes, particularly if they have active MS. Have not seen major side effects again. Should we be concerned about using it in older patients? Possibly we should pay more attention to potential side effects because the immune system changes over time. There could be risk of infection. They have other comorbidities. So again, the time will let us know. But certainly if a patient has migraine with their MS, or they have a heart disease with their MS, there shouldn't be, or at least patients who are having these disorders are usually okay to receive these anti-CD20. we talk about immune colitis. We have seen it in some patients who are receiving certain forms of more these anti-CD20, particularly the intravenous forms. So a patient who have probably ulcerative colitis or Crohn's disease is a patient that you would maybe consider not giving them anti-CD20. Maybe this is a patient whom you should consider giving them
Natalizumab.
natalizumab or some of the sphingosine phosphate receptor modulators.
Yeah. Thank you, Dr. Said. Those were the question, and thank you for accepting our invitation despite your busy schedule and for being with us.
Thank you.
It's really a pleasure to have you and to learn from your expertise in the field of MS.
Thank you, Dr.
And now we move to our Thank you. And now we move to our third speaker. I think now you know very well Dr. Dimasi, who is joining us every month to discuss with us the research topics in the field of multiple sclerosis specifically. So very briefly, Dr. Dimasi is a professor at the Lebanese American University with a PhD in biostatistics. And Dr. Dimasi will discuss tonight survival analysis. Dr. Dimasi, it's always a pleasure to have you with us. You can start your presentation.
Thank you, Maya. Thank you so much. And thank you for everybody for staying with us. I'm going to try and share. Just let me know if you can see my screen well.
Yes. Just
Okay,
go,
great.
just
Yeah,
go on,
thank you.
just go on full mode presentation.
Oh, wait a second. I know what is happening. I'm trying to do that. It's not showing in full mode, is it?
Yes, it is now.
Okay, great. All right. So thank you,
Dr.
Maya,
Dimasi,
for
it's showing the presenter view. So you just, if you
All right.
can
Yeah,
click right on this and just disable the presenter view.
Where would I
Hide
do that?
presenter view. Yeah, hide the presenter view. This is the option.
Okay. Okay, great. Thank you. Thank you so much. Thank you, Maya,
Perfect.
for inviting me, and thank you, Hassam, for your help over here, and thank you everybody for staying for my presentation. I'm gonna talk about basic concepts of survival analysis. If you don't hear me well or if I cut, please let me know right away. Okay. So let's jump into it. The learning objectives of today's presentation is that you should be, by the end of the presentation, be able to identify the aims of survival analysis, define the major components or concepts of survival analysis, and interpret survival analysis results, including Cox Corporation Tassel model. My outline, I'm going to start with an introduction, then I'm going to go over important concepts, then I'm going to talk about what to expect when you're looking at a survival analysis. I'm going to finish up with one slide that is issues to be aware of. And finally, I'm going to talk about comparing survival analysis to other analysis and mainly logistic regression, because this is a very popular analysis. So without further ado, let's talk about a general introduction. The way I think about survival analysis, it's the driving force behind a question. So let me give you an example. If you wanted to test how long batteries last, what would you do? And I'm hoping that hopefully what you would do is you get a sample of batteries, you make them run till they die, and then you measure how long they lasted, and then you calculate an average time for the battery lasted. And you would be fine doing so as long as you had enough time to measure all the batteries. But let's suppose, for hypothetically, that you were doing this in a lab and you were allocated a time period, and your time period ended, yet you still had some batteries running. Then what would you do? So I'm not going to answer that question. I want you to think about it, because this is partly part of the driving force behind survival analysis. Another reason why we do survival analysis, think about another concept, another setup. Let's suppose you wanted to compare two groups in terms of an occurrence of a disease. If the disease happens in certain people, but not in everybody, then what you could do is you could look at the two groups. So maybe group 1 is exposed to something and group 2 is not exposed, or group 1 is taking a medication, group 2 is taking another medication. What you would do typically is you look at the outcome. What is the percentage of those that had the outcome in group 1 versus those that had the outcome in group 2, and you will be able to compare. The problem or the issue is, what if ultimately everybody is going to get the outcome? So what if at the end, everybody, 100% group A and 100% in group 2? Again, what would you do? And based upon the two examples I introduced, the concept of survival analysis comes in handy, because what survival analysis does, it helps answer a very important question of time to event. How long before the outcome occurs? And that's basically what survival analysis is all about. So not only you're comparing the rate in groups of a certain outcome to occur, but more importantly, how long before it occurs. And interestingly enough, you don't have to have the outcome occurring in everybody. So your follow-up may end, and you may have still people that did not have the outcome. So going back to the example of the battery, and yet you can run some analysis and you can answer some research question. So why survival analysis? If the outcome was to occur in all participants, then it wouldn't be a problem. However, typically what happens is that the study period ends and many participants haven't had the outcome yet. And hence there is an interest in looking at time to event, but the time to event may not be known for everybody. So an important thing to do before we continue is we need to define or go over key concepts for survival analysis, and we have 3 of them. The types of outcome that you may encounter during survival analysis, a very important concept, which is the censoring concept in survival analysis. And number 3 is the survival versus the hazard function. So let's start with type of outcomes. Typically in survival analysis, maybe this is like where it came from, is you're looking at death. That would be the outcome. How long before patients die? And I'm thinking probably more of like a very severe cancer type of studies. It could be any cause of death, or it could be a cause-specific death. Another outcome could be how long before a certain disease occur. So you may be doing a follow-up before myocardial infarction occurs. That would work too. Or you could be looking at relapse. So you may have patients that had, or people that have illicit drug problems, they've treated, and you follow them up before they relapse and start taking illicit drug again. Or, for example, depression. It's quite known that patients that have an episode of depression might have another one in the future. So how long before they have their other episode of depression? Or in the example of multiple sclerosis, there is the relapse. So how long before the relapse? As I mentioned, cancer studies got very specific with survival analysis. So they have a very specific, very defined outcome: overall survival, progression-free survival, time to progression, time to treatment failure. They're very, very specific in terms of what to look for. But that's not it. There are other outcomes. Like for drug utilization, one thing you can do is you can look how long before the drug becomes non-efficacious anymore. So you're treating someone and then over a period of time, the drug doesn't work. Or maybe how long before the patient become non-compliant, like a drug resistant, for how long before. Vaccination studies, you can look at if you vaccinate, how long before a patient actually get the disease. You know, they're not supposed to get the disease, but, you know, like an example is what happened with Corona. Most of us got vaccinated, and most of us got Corona after being vaccinated. But if there was a delay in the time between vaccinated and non-vaccinated, if vaccination can reduce the load of patient in the hospital, then it could be very useful, right? Similarly for like allergy studies, again, like maybe you're not going to prevent allergies, but you can maybe delay it, reduce how fast it is happening. So these are different types of outcomes that survival analysis look at. The second concept that is very important is censoring. So remember at the beginning, I said maybe you follow-up time is not enough, or your period of study ends, and yet there are still people that did not have the outcome. So the time of the event is not known for these people. Well, this is what we call censoring. And there are two types. Actually, there are three, but we're just going to focus on two major types of censoring. Something called right censoring and something called left censoring. So what's the difference between the two? Well, right censoring, basically what I mentioned, you're following up a group of people, or you're following up participants, and then the study ends, you're no longer following up the participants. They may still have the outcome, but you're not there to observe it. So you don't know what happened to it. So that's the right censoring. Right censoring is when the time of the outcome is unknown. It can happen for two main reasons. One is what I mentioned. You're no longer following up the participant, the study ended. The second reason is that the person is lost to follow up. Lost to follow up can happen for multiple reasons. As in the name indicated, you're no longer following up the patient, you lost them, something happened, they moved, they went to another country, you lost your contact information, so you lost them. Or they refuse to participate in the study anymore. So you've had them for the first year, the second year, the third year, but then they don't want to participate anymore. Or they may have an outcome that make it impossible for you to assess the outcome you're interested in. So in the example of depression, if you're following up people till the depression occurred, if something else happened, maybe they went into a coma, okay? That coma will make it impossible for you to assess or to measure depression, okay? So all of these lead to something called right censoring, meaning right censoring is when the outcome is not known, the duration, you're following up to a certain point, but you don't know what happened. Left censoring is the other way around. So you don't know when the survival started. So like, for example, vaccination till the outcome occurred. You need to know when vaccinations happened. If you're following up people and you don't know where exactly they got vaccinated, so you know they got vaccinated in the past, but you know exactly when, so you started following them up, then this is left censoring. I have a graph just to like illustrate the idea. Down there is time. The red line, study starts. The green line, study ends. When you have the X sign, this is where the exposure starts, the outcome occurred. And you can have three types of things happening. You may have someone that started and ended, and you know exactly when the exposure started, exactly when the outcome, so there is no censoring in that example, in that person. Another one where you know where the exposure started, but the study ended and they did not have their outcome, and the outcome occurred beyond that, so beyond the green line. So that's a right censored. And the last example is where the exposure started before the red line. And there's no way you can ascertain when it happened. And therefore, that's a left censored. Okay, so last part of the key concept are survival hazards function and the survival function and the hazard function. So the survival function is nothing but the probability that a certain person survived up to a specific point. And as time passes, obviously, the survival probability is going to drop. So typically, a survival function starts at 100 and it starts dropping down as time is passing. The hazard function is kind of like the opposite. It's the probability that if a person survived all the way up to a certain point in time, what is the probability that they will have the outcome at that specific time? So again, it works the opposite way. It starts at 0 because no one has the outcome at the beginning. And as time is passing, it picks up and it goes up. And theoretically, it can go all the way up to 100%. So now that we've covered the basic concept, let's discuss what can you expect to see in survival analysis. And you can expect to see 5 things in survival analysis: the estimate time for survival, survival curves, comparing survival curves, survival up to a certain time point, and finally, the Cox proportional hazard model. And let's talk about them one at a time. The first thing is you want to estimate the survival, and you can do it using 2 ways, either the mean and the median. As a reminder, the mean is an average. The median is the middle point. It's where the 50th is the 50th percentile. 50% of the values are before it, 50% are above it. And again, as a reminder, the mean is very sensitive to extreme values. So if you have 1, 2, 3, 4, 5, and if I asked you to calculate the mean and the median for these 5 values, will both be equal to 3. However, if we change the last value from 5 to 50, then the mean jumps to 18.3, whereas the median remains at 3. Okay? So therefore, the median is less sensitive to extreme value, and it's stable. The reason I say this is because in survival analysis, you're going to have few people with very long survival time, and therefore they will influence the mean survival greatly. And therefore, the median of survival time is something that you will see reported more frequently than the mean, because it's more stable, and it kind of like represents the middle ground much better than the mean. Now, that being said, it doesn't mean you cannot calculate the average. You can. The problem is, if you have a set of people that did not finish their survival time, you know, like they didn't die yet, if die is the outcome, then you wouldn't know their time of survival. And therefore, there are ways they can do that, calculate the mean, by forcing a stop. And I'm just going to jump into the example. So here's a survival function starting at 1 and dropping over a period of 10 years. And you can see that by the end of 10 years, you still have 20% alive. So what you do to calculate the mean is you're going to slice it into year by year, and you're going to calculate the proportion surviving every year. So the first year, 100%, the second year, 80%, 70%, 50%, 35%. You do that till the 10th year, and then you're going to add up these values, and you get an average survival of 4.75 years. Now, that is condition that you sliced or you stopped at 10 years. If you were to stop at 12 years, you will get a different mean. Whereas the median, which I meant is just the 50th percentile, all you need is 50% of the participant to have their outcome to be able to figure out the median. And therefore, even if you have censored, you know, I can say now right censored, those that you didn't know outcome when it's going to happen, you can still calculate it. And I'm going to show you the same example, you know, the survival curve dropping. You come to your 50%, you extrapolate, and then you figure out that the median for this curve is 4 years. Okay. Now, how do we come up with these survival functions? How do we calculate them? There are 2 major ways to do that. There's the life table, and there's the Kaplan-Meier. And I'm going to do a little bit of math here, because I think it's important for you to understand how the math incorporate the censored into it. But I mean, let's try to see if we can keep it simple. Here's a hypothetical scenario of a study that started in 2001. It ended in 2006. But as you know, people come in and out of the study at different time points. So hypothetically, let's say I have 3 people joining in 2001, 1 dies in 2002, 1 leaves in 2004, so that's censored, and 1 dies in 2005. The study ends in 2006, and here I have that's a mistake. I have 1 censoring here. I'm sorry. It should be 1 censoring. In 2002, I have 2 people that join. 1 leaves in 2003, and the study ends in 2006. And here I have 1 censored towards the end of the study. And then I have 6 joining in 2003, 2 dies in 2005, 4 are still in the study by the end of the study, and then I have 4 censored, and then I have 2 that join in 2004, 1 leaves, and you have 4 that remains in the study, 1 that remains in the study. So what do? We take this data, we calibrate it, or we we put it back instead of calendar year follow-up year. So we created a table like this one where we have the time of joining and we have 1 year follow-up, 2 year follow-up, 3 year follow-up, 4th and 5th, and we build a table like this one. You know, I have the thing that joined in 2001. I know when they died and when they continued till the end. And I do the same thing for those that joined in 2002, but now they're lined up with the same, like I'm having the same starting point for everybody. And I do that again, you know, I follow up every group in terms of what year they died and what year they left and what year they remained. And then I have the total. Then the next thing you want to do for the life table is you need to calculate the probability of surviving. So but you're going to end up doing a table like this one, you know, like the interval year, and survival life table works as 1 increment, 1 year, okay? Next, you're going to calculate how many were at the beginning of the interval. So right at the beginning, you had 13 right at the beginning. You're going to calculate how many died in that interval and how many were censored in that interval. So if you start with 13 and you have 1 that died and 2 that were censored, then in the next interval, you're going to have only 10. And same thing, 2 died, 1 censored. So that's 7 in the second interval. 5 were censored, none of them died. That takes it to 2 in the second interval, and so on and so forth. Okay. Now, the next thing is you're going to expand that table. So the first part is the table that I explained, but the next part is you're going to calculate the effective at risk. So out of the 13 that entered the interval, not all of them are at risk because you have 2 that were censored. And therefore, what you're going to do is you're going to subtract out of the 13 half of the censored. So that's 12. Out of the 10 that entered the second interval, 1 was censored. So you remove 0.5. That gives you 9.5 at risk. And you do that for every interval. And then what you do is per interval, you're going to calculate the risk of dying or the proportion of dying. So you know 1 died, and you're not going to divide 1 by 13. You're going to divide 1 by 12. And that is going to be the probability of death in the first interval. And you're going to do the same thing for the second interval, the third, and so forth. Then you're going to take the cumulative or whatever is left out, and that is going to be your survival in every interval. And you multiply every survival by the subsequent one or the one that is preceding it to get the survival. So the first survival in the first interval is 91. The next one is 72 because it's 78 times 91. And then it drops to 72 again because here's you have 100% survival and then 24% and 0%. And I'm sorry if it's too complicated, but what I'm trying to illustrate here, I'm trying to illustrate the fact that censoring is accounted in the analysis. Now, the Kaplan-Meier analysis is very much similar to the survival table that I showed, the life table, except that it's not a 1 year increment. Rather, the time interval is set by when you actually have an outcome. So over here, this is a different example, and we have a period of time of 4 months, 10 months, 14 months, and 24 months. And the reason of these were picked is because you had 1 individual dying at 1 month, 4 months, 1 at 10 months, 1 at 14 months, and 1 at 24 months. Okay, so you started out with 6 people, and these numbers are dropping out. But you don't, but not all people dying, you also have people censored getting out of your study. And everything else is exactly what we did. Okay, so long story short, in a survival, in a life table approach, you will have the stepwise that is, you know, year by year. And you can go and extrapolate the median as we did a minute ago. However, if you were to do a Kaplan-Meier, then the same data would produce something that is a bit different, okay? And if you try to extrapolate the median, you may get a different result, which is, you know, to be expected because the intervals are different. So these are 2 different ways to create your survival curve. Kaplan-Meier is much more utilized than the life table. Now, Very interestingly, if you were to do a survival curve for groups, you can actually compare them, and you can test to see if there's statistical significance between them. And here I'm showing you an example of this is from an article that we published, and you can see that you have two curves, the blue and the green. So you can see that you're comparing two groups, and you can see that the difference between the two is statistically significant. You can tell it's statistically significant because you have a p-value less than 0.05%, but also because the two lines have split. You know, typically as the survival curve split and they're not crossing each one another, then that's an indication of statistical significance. Here's another example. We're comparing here 4 groups, and you're going to get a lot of p-values. But again, if you look at the blue versus the yellow, you can see that they split right from the start and they're far from one another. So the p-value is statistically significant. However, if you compare the yellow and the green, you can see they're intertwined. So it's not significant. And if you compare the green to the orange, they're intertwining here, they're intertwining here. So again, it's not significant, but there's more. You can compare actually the blue to the green, and again, it's significant. You can compare the yellow to the orange. They're not, because they're intertwining, and you could compare the blue to the orange, and they are statistically significant. So the visual method is very helpful, but you can also request a p-value. You can get it from the log-rank test, the Breslow-Day test, or the Tyrone-Ware test. Each one is emphasizing a certain area of the curve for statistical significance. Another thing you can expect to see in survival is survival up to a certain point, like typically 1-year survival, 5-year survival, 10-year survival. So here we're looking at a graph showing different cancer, and you have 1-year survival, 5-year survival, and the 10-year survival for every cancer. And so you can see like lung cancer down in graph has a very low survival, whereas something like breast cancer has a much higher survival, whether it's for 1 year or 5 years or 10 years. Here's another one. This is 10-year survival looking at all cancer, prostate, lung, and bowel cancer. And you can see like the prostate cancer, the 10-year survival is 84%, whereas for lung cancer, it's only 4%. And what does that mean? That only 4% of lung cancer patients will survive up to 10 years, whereas for prostate cancer, 84% will survive up to 10 years. Again, you can compare different groups for their 5 and 10-year survival. So here again, this is a study that we did, and we're looking at lymph node ratios. This is the 5-year survival for lymph node 3, 4 to 9, or more than 10, and the 10-year survival, and you could see that it's statistically significant. One thing about when you're doing a point-in-time survival that you have to worry about or pay attention to, that you may miss the entire curve if you only focus on that time point. So I'm going to just jump into the example. Here you have 2 lines, drug A and drug B, and obviously they're splitting apart. Drug A is doing much, much better for many, many weeks. But then towards, you know, the 34th or 35th week, it collapses and it reaches the same level as treatment B. Now, if you come here and you compare these 2 treatments at exactly that point, you're going to see that there is no difference. However, that will ignore the slower rate of treatment A versus treatment B. And again, if I bring the example of corona, if I'm able to slow down the disease, everybody's going to get it, fine. But if I can slow it down, then my health service, my hospitals, they can, you know, have enough time to receive patients, to treat patients, send them home, get a new bunch, instead of being overloaded with patients. Finally, the last thing you can expect to see is what is called the Cox proportional hazard ratio. And as I've already mentioned, hazard is like, it's the opposite of survival, and it likes the probability of getting the outcome at a certain point in time, and it changes over time. The Cox proportional hazard ratio analysis produced something called HR, which is the hazard ratio. And typically, it's a ratio like a relative risk or odds ratio. It's comparing 2 groups. and it works exactly like a relative risk. If it can go from 0 to all the way to infinity, passing through 1. If it's equal to 1, it means there's no difference in survival between the two groups. If it's greater than 1, then there's increased hazard in the treatment versus the placebo, or whatever, group 1 versus group 2, and therefore the treatment has a shorter survival. It's less than 1, it means that there is a decrease in the hazard, and therefore there's a longer survival for the treatment. And it needs to be interpreted for statistical significance using the p-value and the confidence interval. The Cox proportion Hazel model is built like any regression model. It has a y, which is the independent, and it has a x, which is the dependent. And if I want to simplify it, it looks like y equal a plus bx. Y is the dependent, x is the dependent. And it turns out if you take this beta, this b, and you exponentiate it, it will give you the hazard ratio, provided that you coded your independent variable as 1 and 0. And you can actually extrapolate it into a multivariate model where not only you have the treatment, the most important variable, but you can also have covariates to control for, confounders and bias and stuff like that. And if your confounder or your or has more than one group, then you have to build a dummy variable. So let me give you an example. This is a study that we did, and one of the confounding variable was the stages. So we had stage 3A, 3B, and 3C. 3A is playing the role of the reference, so it gets a hazard ratio of 1 because it's the reference. There's no confidence interval, there's no p-value because it's the reference. Whereas 3B produces a hazard ratio. It's compared 3B like 3A. It has a hazard ratio of 0.84. The confidence interval right here, 0.18 to 4.24 is crossing 1, and the p-value is greater than 0.5, so it's not statistically significant. Same thing for 3C. Again, same idea over here. I have a hazard ratio, Cox proportion hazard ratio, multivariate with many variables. I will have a hazard ratio, confidence interval, and a p-value. I'm focusing on the receptors for the estrogen progesterone. The reference is both are positive, so that's a reference. Here I'm comparing one of them is negative versus both of positive. The hazard ratio, the confidence interval crosses 1. It's not statistically significant. However, if you look at the second one, here you have a hazard ratio for both negative versus both positive. And the hazard ratio is 2.58, indicating an increase in the hazard for the group with 2 negative versus those that are 2 positive. The confidence interval does not cross 1, and the p-value is less than 0.05. Both confidence interval and p-value are indicating statistical significance. Last, I want to point out that this p-value is not for the reference. This p-value is for the overall, the omnibus test of this variable. There is effect somewhere, but it doesn't tell you where the statistical significance is. The separate p-value actually are telling you where the significance is. Issue to be aware of, so we're getting towards the end. Thank you for bearing with me. Censoring, we have to make sure that the censoring are happening at random, meaning that those that are censored do not bear a different risk of the outcome than those that are not censored. Otherwise, then there is a bias introduced. Follow-up time, you need to plan your study with enough time to follow so that enough of the participant had the outcome. So if typically, let's suppose the median time for the relapse in the study is a year and a half, then plan your study for at least 2 years. Don't do a study for 6 months, because by the time the study ended, no one had the outcome, or very few had the outcome. So follow-up period has to be related to whatever the disease is. Sample size and power, the sample size and power of the study reflects on the number of those that actually had the outcome rather than just the sample size. And the rule of thumb says that if you're doing a Cox proportion hazard model, you need 10 events per covariate, which takes us back to the previous point. You need enough follow-up time to have enough outcome occurring. And also, there are ways that you can test the goodness fit of your model to see how much your model is actually fitting the results, to give you an idea of how well is your model performing. Last is, how is survival analysis different than, let's say, logistic regression? Well, the easiest way I can answer this question is by telling you like the different research question each one is saying. So survival analysis would answer a question, how long will it be until a patient stop responding for treatment? You know, how long before? Whereas a logistic regression question will answer a question, will a patient stop responding to treatment or not? Okay. So in conclusion, survival analysis is a useful technique that answers a unique research question. You know, how long before, the time to event. It's practically, it has practicality in many areas, you know, namely cancer study, of course, medication utilization, insurance, and even engineering. You will see survival analysis in a lot of fields. Every time you're interested in how long before someone learning to drive before they make an accident, for example. Or how long before you will apply for a renew of a visa, you know, any kind, as long as you have this question, you could do survival analysis. It produces a very useful graphical display of the survival function, which you can read and you can extrapolate a lot of information. In addition to the Cox proportional hazard model, which allow you to control for confounders and biases. So before we finish, I thought it would be maybe helpful to have a self-test. I'm going to ask you 6 questions. See if you can answer the question. And hopefully if you do like 3 out of the 6 or 4 out of the 6, then that would be very good. So first question, what I'm showing you here is a drug survival for DMT. And I borrowed this from Maya. Thank you. I borrowed this graph from your ECTRIMS presentation in 2023. So first question, if you look at this graph, how many drugs are being compared? I'm hoping you will be able to look and see that there are 3 lines, and therefore there are 3 drugs. Second question, how long was the follow-up?
So the chat is activated in case the attendees want to answer. So for the first question, I have 3.
Great. Second question, how long was the follow-up?
10 years.
Great. Is this a survival or a hazard function?
So 10 years, 10 years, it's a survival. They are
Absolutely. It is a survival because it's starting at 100 and it's dropping down. A hazard function would have been exactly the opposite. So great. If you get 3 out of 3 so far, this is wonderful. Is there evidence that one of the drug is doing different than other drugs? Remember what I said about, you know, visually you can inspect the lines and visually you can guess if one is different than the other?
Yes, they are answering yes.
Great. And hopefully you can visually see that it's the red line that is completely separated from the blue and the green. What is the median survival for the red line? So remember, on the y-axis, you have the percent survival. The median is at 50%. So go visually on the 50%, extrapolate to the red line, and then drop down to the x-axis to see what you get.
The answers are, I have 10 years, I have 5 years.
Probably the 10 years is still answering the how long. So you're going to come to the 50% right here. So this is 40%, this is 60%. You're going to extrapolate and you're going to drop down. And the answer is about 5 years. And last question, if I was to do a hazard ratio between the red and the blue, okay, so the red versus the blue being the reference, would the hazard ratio be less than or greater than 1? So I'm putting the red on top of the blue. Which of the two has a higher risk of death? So would the hazard ratio will be greater than 1 or will it be less than 1?
Greater than 1.
Absolutely correct. So thank you so much for bearing with me, and thank you, Maya, for inviting me. Thank you, IVPN NeuroPsychiatry, for this wonderful opportunity to meet a lot of people. So, and thank you, Novartis, for sponsoring the event.
Thank you, Dr. Dimasi, for an amazing presentation. And it seems that you met all the learning objectives, since most of the attendees answered the questions,
Wonderful.
the self-test correctly. So allow me just to take one question. I know that we are ahead of time. So one of the questions is, what are the limitations of the log rank test when comparing survival case between two or more groups? And how do alternative tests like Wilcoxon, Tyrone-Ware test differ from the log rank test?
So
And
I'm sorry. Yeah. Do you want me to answer, or do you want to finish ask another question?
and just they are asking you in what situation those tests they might be preferred.
Okay, so in my experience and from many publications that I've seen, the majority of people go for the log rank test. This is the most widely used one. I had a slide where I explained the difference between them, and I'm sorry I went through them quickly. Some of them favors the statistical detection at the beginning of the survival, some of them in the middle of the survival, some of them at the end of the survival. So probably depends on the kind of analysis you're interested in. So the example of the vaccination that I gave, where everybody's going to end up maybe having the disease either way, maybe the focus is more on the middle, because that's where the importance is. Whereas if you're doing like survival for drug persistence and you're interested on carry over, like how long they will remain, then maybe the log rank test might be more appropriate.
Thank you, Dr. Dimasi, again for accepting our
Thank you.
invitation for
Thank you.
this very
And Eid
informative.
Mubarak to everybody. I know this is right after the Eid, so thank you for
Yeah.
those that have joined us right after the Eid.
Yeah, and despite that, it was the first webinar after the Eid, and probably many people are still in taking their Eid holiday. We
Absolutely.
had more than 400 attendees today joining us for this webinar, and they stayed with us until the end. So let me start by thanking all our attendees who joined us despite the Eid holiday, and for being loyal to attend this clinical and research multiple sclerosis series. And I would like to thank also our three speakers, Dr. Suzanne Nouri, Dr. Areen Saeed, and Dr. Dimasi, for being with us tonight. I would like to remind our attendees that this webinar is a CME accredited webinar, and you will receive your certificate of attendance by email within 1 week of today. If you missed any of those lectures, or you would like to revisit the lecture, the presentation, or the whole webinar, you can visit our IVPN library, where you can access the recordings of these webinars. However, you have to be a member. You have to sign up for membership, for IVPN NeuroPsychiatry membership or IVPN membership, in order to access and revisit the lectures. And all the recordings of this webinar and previous webinar are posted in our IVPN library. Also, don't forget to follow us and keep your eyes on our LinkedIn IVPN NeuroPsychiatry page, where we post all our educational activity. Finally, let me thank Novartis for sponsoring those educational. Thank you so much, Novartis, for supporting us. And I would like to announce that this, unfortunately, is the last educational activity before the summer break for the IVPN NeuroPsychiatry, but definitely we will see you next September, break or holiday, and we will resume our educational activity in summer 2024, in September 2024. So stay tuned. Again, keep your eyes on our social media platform, and all the upcoming webinar planned for September 2024 will be announced in our social media platform. Until I see you again, stay safe and enjoy the summer vacation, and have a good night, everybody.